Good morning, everybody. How's everybody doing today? Are you liking this fresher weather? Isn't that great? And I do welcome you to be here today. I am president and founder of MS Views and News. This is officially our 11th MS Symposium. Isn't that great? 11 years we've been doing this. So, I wanted to thank our sponsors of today's program. All right, we have a lot of sponsors today. I'm sure that you made it through our resource room. We have our platinum sponsor is Celgene. We have bronze sponsors of Memorial Healthcare System, Sanofi Genzyme, Novartis and Genentech. We have our community sponsors of Mallinckrodt and Curaleaf, and we have our educational supporter is Biogen. And I hope that you could all give them a round of applause because they deserve it. All right, in addition to them, we have, well, I want to thank all of you for attending, all right? So my thanks to all of you for being here. Thank you very much. We also want to give thanks, please, to our volunteers, all right? My family. We have a lot of family here today that are helping out, all right? And again, the MS Views and News staff. Of course, we should give everybody a round of applause, all right? Thank you. Thank you. Connie Easterling is an adult registered nurse practitioner and clinical coordinator of the MS Care Center at Neurological Services of Orlando. She's a graduate at the University of Florida. Her practice has been limited exclusively to multiple sclerosis since 1998. Connie promotes MS education by speaking frequently to community, student, and professional groups throughout the United States. She's previously served on the consortium of the Multiple Sclerosis Board of Directors. She's a past president of the International Organization of MSRNs. She's serving on the board of directors has been on the MSRNs since 2006, from 2006 to 2017. In 2009, she received the June Halper Award for Excellence in MS Nursing, an award that signifies energy and purpose to provide the most up-to-date, comprehensive care possible. Let's welcome Connie Easterling.
So today, Stuart asked me to speak to you about women's issues, and so I'm going to do so. A few of the points have been covered, but I don't want to go over those again. And Stuart is going to cut me off if I'm not done in 35 minutes. I'm never done in 35 minutes. So, and I'm glad that you have the slides or you will be getting the slides, because my slides are very wordy, and they're wordy for a purpose, so that you can read them, and so that students can read them. And so when it comes out on YouTube, you'll be able to look through the slides more slowly. So what we know about women in MS, we know that there are 3+ women to every man with MS. We know that the average age of onset for a woman is 32 years old. We know that the younger of MS onset, the younger she is when she starts her menses, the higher risk for MS. We know that contraception is very important, especially to women who are taking a disease-modifying therapy. And we know that MS creates challenges in maintaining intimacy and relationships. We're going to talk about intimacy in just a few minutes. So individuals with MS are at a higher risk for osteoporosis or osteopenia after menopause, and only 19% of MS women are offered information or counseling about sexuality. And it's very hard for many of them to find someone that will talk to them about that. We're going to talk about sexuality today. So these are just some things that we're going to cover and things that are important to women. So let's talk about MS and relationships. So Dr. Harris talked to you about how many people go through anxiety and depression and other stages of grief. I want you just to remember that your family goes through those stages as well. Your spouse, your children, and I want you to remember that there's going to be an adjustment period. But during that adjustment period, make sure you include the children. You know, depending on their age, it's very important that they know that there's something new in the family. There's something new about mom or about dad. And so you give them age-related literature but you include them in the family meeting. And when things change, always, because they're going to know, and they're going to know when something's wrong. So if you go behind the door whispering, they can really get a little bit depressed and anxious about that. So regarding significant others, with your significant other and you, make sure you make a commitment. Become a team. My husband and I just had our 50th wedding anniversary Thursday, and thank you. And we really are a team, but that took a lifetime to develop. So be a team, communicate. I think throughout this program you're going to hear honest and open communication more than 50 times. So you want to release stress. Remember, talking about things can release stress, can ease stress, and listening to the other members of your family, especially your significant other. You need to state your issue, your needs, and they need to state their needs and their concerns, and everybody has an opportunity to share. So remember to prize your significant other, meaning do something nice for your care partner, your significant other every day. So the roles in the family are varied. I remember the days when I was growing up a long time ago, and the mother stayed home and cooked, and the dad went to work, and the kids did their chores. It's very different now. My husband does all the cooking. I don't cook. I like to cook. I cook at Thanksgiving or Christmas, but he does all the cooking. I wash some clothes. I may clean the house. But we do have varied roles, and sometimes those change. In the family where MS is present, the roles may change quite frequently. So again, communication is the key. Have that family meeting. If things aren't working for you, you can't stand at the sink and wash the dishes, it's uncomfortable, or there's other things at home that somebody else needs to take on, make sure you communicate with your family, include the kids, because we have a grandson living with us, and I told my husband all he ever does is take the garbage out, only if you make him do it. So we're re-evaluating the roles in our house now. So there are a lot of resources, and you should choose your resources, be willing to negotiate, state your reason, pick your decision, and let them know what your decisions are and what your needs are. So let's talk about MS and family planning. Women with MS tend to have fewer children than women that don't have MS. And we believe it's because they're concerned about the future. And of course, there's a lot of uncertainty. So they don't want to have to be disabled and taking care of kids, or they're afraid of that. So it's important to talk to your significant other, plan the number of children that you want, and a planned pregnancy is best. You'll hear that a few times, and make sure you know your resources. So before you get pregnant, or before you plan to get pregnant, just know what obstetrician you're going to go to, talk to your neurologist. A long time ago, we used to say, if you're going to have babies, have them now. Have them now while you're young, or have them now before you get disabled. But we don't say that so much anymore, because now we want you to maybe be on a disease-modifying therapy for a year or two before you get pregnant. So only 25% of those with MS report another affected member in their family. So we want you to know that MS is not a inherited disease, and we want you to know that it is not a genetic disease as well. So family members may risk the disease. If you have a first-degree relative with MS, risk increases from about 0.13% to about 2.5%. If you have another parent with MS, or if you have both parents with MS, your risk may increase to 5%. And in some literature, it says 14%, but that seems awfully high. So a sibling with MS may cause greater risk than just having one parent with MS. And if you're a twin, your risk of MS goes up for your other twin to get MS up to 30%. There are modifiable risk factors as a parent that you can instill in your children. So if you're concerned about them developing MS, make sure that that their vitamin D level is normal, and that may vary according to their age. And make sure that it's a good level, not the lower end of level, but the good level. And then monitor and manage their salt intake. Salt is inflammatory to the MS body, and so you can teach your children to modify their diets as well. And then adolescent obesity is considered one of the main reasons that children get multiple sclerosis. So we want you to make sure you talk to your children, make sure their age appropriate, their weight is appropriate for their age, and consult their pediatrician too as needed. And then smoking. Smoking's dangerous for the MS patient. It's the one significant factor that can cause disease progression and more aggressive disease. So make sure that your children know that and monitor that as they grow up. Okay, pre-pregnancy planning. So it's important for you to plan your pregnancy. The disease-modifying therapies used for 1 to 2 years before pregnancy can decrease postpartum risk. Newly diagnosed women may want to or may be advised to take a disease-modifying therapy 1 to 2 years before they get pregnant. Women that are newly diagnosed at a young age, they tend to be very anxious to have a baby, but we want them to be very healthy before they get pregnant, because the year before pregnancy, the year after pregnancy, after the baby's born, mimics the year before pregnancy. So if you had very aggressive disease at the time you get pregnant, it's likely that your disease will be very aggressive after the baby is born. So it's very important that you have a good year, maybe 2 years. So, and the wellness measures before pregnancy are really important. I know Megan talked to you about wellness, and all of those things she told you about staying well and healthy are very important. So before you get pregnant, make sure that you have a normal vitamin D level. Use prenatal vitamins before you get pregnant, and folic acid. Folic acid is very important, but you'll need your doctor to evaluate what your folic acid is as to how much you should take. But take those prenatal vitamins. No smoking. Smoking is bad for the baby, bad for you, bad for your kids. It's all around bad for everybody. So, and then limit alcohol use before you get pregnant, and make sure you have good sleeping habits, because not only won't you get as much sleep after the baby, but during your pregnancy we want you to be healthy, and sleep is very important. So contraception is important. The goal is to avoid accidental pregnancies. I got 2 babies that were accidents in my lifetime, and a lot of women are not cautious about contraception. So we want to avoid an accidental pregnancy so that you can have the best outcomes. The disease-modifying therapies are not approved for use during pregnancy, so and you should stop your disease-modifying therapy before you stop your contraception. Stay on your contraception until you're ready, but discontinue that disease-modifying therapy. Now, we do have some that are considered safe to take while you're pregnant if your disease is aggressive. So Copaxone is one, and the interferons are now proposed to be safe during pregnancy. But we don't want you on those. They're not approved, and we want you to have the best outcomes. Nobody knows what could happen if you take those disease-modifying therapies during pregnancy. So discontinue the disease-modifying therapy, stay on your contraception, and then the best contraception that has been found to be the most effective at 99% or more is intrauterine devices and the hormonal implantable rods. So those two, they're reversible. We want you on a reversible type of contraception. And then there's no contraindication with using these with your disease-modifying therapy. If you look at this frame, this just tells you the washout period for most of the drugs that we have out. I heard we had 18 new drugs for MS since Volmarity came out. However, I had a hard time yesterday counting all 18 of them, but so these are some of the drugs require no washout. You can go from no drug to pregnancy the next day, but the majority of them require some time. 10 days, 2 months, 6 months, 4 months. Follow the recommendation of your physician, your neurologist, and your obstetrician. They will certainly have an opinion on this. And remember, teriflunomide stays in your system for an extended period of time, up to 2 years, and you may want to do the accelerated elimination process. If you don't, you might be at risk of putting the fetus at risk, because that drug does not appreciate pregnancy at all, so it's very dangerous. Okay, MS and pregnancy. So in relapsing remitting MS, pregnancy does not worsen long-term prognosis of MS. In some studies, pregnancy even has beneficial long-term effects for the female. MS is not associated with decreased fertility. It's not associated with stillbirths. It's not associated with cesarean deliveries or any type of birth defects. Babies born to mothers with MS may be slightly smaller, but we believe in many cases it's because the physician, the obstetrician, wants you to have a cesarean section. Sometimes if the mother has weakness or spasticity in the lower extremities, or she cannot help deliver that baby by pushing effectively, he's going to schedule a cesarean section, and usually they do those a little bit earlier. Then there are other thoughts that innervation of that part of the body may be affected by MS. Deliveries are more complicated if there's a level of disability in the woman. Pregnancy should not be considered high risk, but do you know what most obstetricians do? They refer women to the high-risk clinic, and that's not necessary, but they feel more comfortable doing that anyway. So, and then the bottom line is that MS does not put the fetus at risk. Now, some of the treatments we use could put the fetus at risk, but pregnancy itself is not a risky event for the baby. Now, if you look at these MS symptoms, these are many symptoms that patients with MS or women with MS feel every day. However, these are symptoms that become worse during pregnancy. If you've ever been pregnant, you know fatigue gets worse long about that 3rd month, the first trimester. You can have bladder and bowel dysfunction when you're pregnant, mostly because the baby's sitting on the bladder. But remember, if you have bowel and bladder dysfunction before the pregnancy, it's likely going to get worse during pregnancy. And part of the reason that some of these symptoms get worse is that you cannot take symptom management drugs when you're pregnant. So what happens when a patient comes in or they call me and they say, I'm pregnant, I say, stop your disease-modifying therapy, stop your antidepressants, stop your medicine for spasticity, stop your walking drug. We don't write any more prescriptions for 9 months. And everything that the woman is prescribed has to come or by the approval of the obstetrician. Okay. The protective effect of pregnancy, we know that it's like the body goes into its own natural state of immunosuppression, but not really. It is known that pregnancy is an immunotolerant state, and there is protection of the mother and the baby during that time. Environmental exposures have effective on genetic risk. So there was a study a few years back, and I don't think anybody's done anything with that. I haven't seen anything, but women with MS who live in the northern hemisphere and have end of winter month births, April and May, those are associated with an increased risk of MS compared to the end of summer months. So women in general, if you have a baby in May or April, that is associated with increased risk compared with babies born in October or November. That was an interesting study. Studies also show that pregnancy may not have long-term benefits in relapsing remitting MS. So there was a study a number of years ago, I think it's quite a number now, but it was a 10-year study, and they studied thousands of women through observation. Through observation. And the lower the EDSS score at 10 years of the trial, pregnant. Okay, so the lower EDSS score was found in the women who'd had at least one pregnancy. The women that did not have a pregnancy during that 10-year period or had never had a pregnancy, they were at greater risk. So there's something to be said for the hormones in a woman's body. Very important. Relapses during pregnancy can mimic the year prior to pregnancy. As I said, relapses are at 60 to 70% lower during pregnancy and can occur at any time relapses can occur at any time during pregnancy in all trimesters, but there's less risk in the third trimester. Studies show that relapse rates during pregnancy occur at about 15 to 22.5% of women. High-dose short-term steroids are safe in any trimester. Now, we used to say you couldn't have steroids till the third trimester, but now there's different thinking now. So you can have low-dose, maybe 3 days, maybe 500 milligrams a day, maybe 1,000 milligrams a day. The doctor will determine, but you shouldn't probably take 5 or 10 days of steroids while you're pregnant. MRIs are considered safe. Most of the time we don't do MRIs while the woman's pregnant, but now we consider it a safe option, but you cannot have the dye, the gadolinium. That we won't do because that may go right to the baby. And doing them anyway during pregnancy is quite controversial. So MS is compatible with any choice of delivery. So you can have spinal anesthesia, you can have an epidural, you can have any that you want, but most anesthesiologists do not want to do an epidural on MS women, and we don't quite understand that. They're not comfortable with it. So that is something you would have to talk to them. You may want to consult with a nurse practitioner who is who works in anesthesia and provides anesthesia. She might be more open to epidural because most women want that epidural to relieve pain. So there's an increased risk for relapse during the first 3 months postpartum. I think it could be even a little bit longer than that. But again, if you're healthy and you were healthy that year before pregnancy, you should do fine. So disability pre-pregnancy and relapses during pregnancy are associated with increased postpartum disease activity. So I had a patient one time, I'm trying to look at my time, had a patient one time, she was 35 years old, and this is a few years ago. She was somewhat disabled, she had cognitive decline, she used AFO on both legs, she walked with a walker, and she wanted to have a baby. She wasn't married, she'd never been married, and we knew that because she wasn't stable with her MS, that it was likely not a good option for her, but she didn't like that recommendation, so we didn't see her for a few months, and she came back and she was pregnant, and she was not married with a father. She lived alone, she didn't have family here, didn't have sisters, brothers, mother, father, aunts or uncles. And so when she got pregnant, the father of the baby moved into the house with her. And later on, as the baby grew, I started getting calls from the sheriff's department in Orange County. The baby, 2 years old, 3 years old, was in the yard. She could not safely care for the child. She couldn't chase the child when it started walking, and they wanted to know what I was going to do about it. Well, of course, I can't do anything about it, but however, she got sick, she had a relapse, and she went into the hospital, and after that was significant, and then she went into a nursing home. And she named her baby Tabitha. And after Tabitha was 3 years old, she never saw her again because the father of the baby took her and left the state. And she had no consequence. I haven't heard from her in a number of years, and she may either still be in the nursing home, I'm not sure. But she never did get to see her baby. That's what I've been told. So we know that breastfeeding is an issue. Women have to decide when they're pregnant, before it's time to have the baby, whether they want to breastfeed or not. And there's a lot of controversy about whether that's beneficial or not. Recent studies on breastfeeding have observed that there's no negative effects of breastfeeding. on the woman. Interferon and glutathione acetate are believed to be compatible with breastfeeding, and that's good for the mother and for the baby. Breastfeeding for an extended period of time. This is a study that came out recently, and it's not conclusive. So it's going to take more study and trials to see if this is true. But breastfeeding for an extended period of time, more than 4 months, may lower the risk of future MS in the child. If you breastfeed for 15 months or longer, it may lower the risk for future MS in the mother. So that really tells us that female hormones are very important. Breastfeeding for a baby is preferable by pediatricians. And of course, the ladies in the hospital, when you go deliver, they like you to breastfeed. But it's a choice you have to make. You do not have to breastfeed. And it depends on your ability to breastfeed as well as maneuver through that process. So let's talk about menopause really quick. I think there's a few women in the audience that may be approaching that phase in their life. So menopause is when your menstrual periods stop. It usually occurs around the age of 51 to 52. The common symptoms of fatigue, depression, cognitive changes, poor sleep, headaches, bladder dysfunction, sexual dysfunction, and hot flashes get worse during menopause. And they get worse during your menses as well. So that's another topic we don't have time for today. So women in menopause have very special needs. There's an increase for cardiac risk. There's an increase of osteoporosis during the years of menopause, and so we have to actively work with the patient and with their primary care physician to make sure that they are cared for and assessed and treated properly. Men, you do undergo andropause. Have you ever heard of that? That is a drop in your testosterone level, and it occurs around the age of 30. So men go through their menopause, as they say, much earlier than women. I saw my doctor the other day, and his aide is a man. We love Don, he's great, but he sat down in the chair. I came for me, but if he sat down in the chair and he says, I need to talk to you. He said, I'm really having fatigue, and I'm having mood disorders, and I'm having this and I'm having that. He said, what do you think's wrong with me? And I said, andropause. Well, he didn't like that much, but I did refer him to his urologist because urologists take care of those issues in men. So symptoms of menopause do overlap with MS symptoms, and so they only, I think, are embellished during that time. So hormone replacement therapy can really improve the symptoms during menopause, and it can stabilize disability, but you have to talk to your healthcare provider because not all women can take hormone replacement therapy. We know that there's increased risk of breast cancer. There may be increased risk of deep vein thrombosis, especially if you are in a wheelchair or sitting most of the day. And so that all has to be evaluated. Also, hormone replacement therapy can be topical. It can be orally. It can be in the vagina. So it's relatively easy to take, but we do not in neurology order hormones for anybody. That has to come from your primary care physician or your gynecologist. So they will discuss the contraindications for HRT, and some antidepressants and other provide a symptomatic relief for some of the symptoms that get worse during pregnancy. And wellness. I won't go into wellness because Megan did a great job, but if you institute all those wellness measures, it's going to help you feel better, and it's going to help your lifestyle. So remember, this is not part of my program, but remember that the more diagnoses you have outside of MS, let's say you're a man with hypertension, with diabetes, or a woman with hypertension, diabetes, high cholesterol, it makes it harder for your brain to stay well. Did you know that? And so over time, your brain can't take care of you. So those relapses may be more difficult. Symptoms of MS may progress. So you want to make sure that your brain stays healthy. I think Gretchen talked a little bit about the brain, and it's a unique organ. Let's talk about intimacy and sexuality. If you ask a man about intimacy, he's going to say sex. A woman is not going to say sex. What do you think she would say? It's going to be an emotional relationship. Women are very emotional. Intimacy is that sense of closeness that comes when we share deeply with another person. But there's just different types of intimacy. There's intellectual intimacy when you share your thoughts. There's emotional intimacy when you discuss your feelings. There's social intimacy when you spend time together and discuss the time that you spent apart. There's spiritual intimacy when you open your soul to each other. And then there's sexual intimacy when you share your bodies. So just remember, sex is only a part of intimacy. There are other ways to be intimate. Sexuality is defined as it's more than sexual function. It's an ever-changing lived experience and is always affected by the manner in which we view ourselves and our bodies, and it's associated with constantly changing social and cultural influences. And women, I do want to say to you that many times if you have physical disabilities, you have low self-esteem. And then you have a poor body image. But you need to remember, and you get counseling if you do, but remember, you are a being. You're a beautiful being inside. You need to pull forward that woman that you were before you got MS. Because that's who you really are. It's not the person that uses a walker. It's not the person that wears an AFO. But it's that person inside that has feelings, that has personality. So I read an article the other day, and the psychologist said, take out all the pictures in your house of you when you didn't have MS, and put up pictures of you with your MS, so that you learn over time that this is you now, and you need to pull forward that woman. Be happy, be positive, be enjoyable around other people. And after a time, they won't see that walker, that AFO, or that cane. They'll see the inward you. Okay, most men and women rate sex as important in their overall life. 68% of men, 83% of men said it was important, and 63% of women. Sexual dysfunction can occur as early as 2 to 5 years after diagnosis. The youngest person I ever had with sexual dysfunction was 19 years old. And with her first relapse at the time of diagnosis, she had numbness and tingling from her waist down, and she was in a relationship with a young man, and it was devastating for her. She could not have a climax. And so we worked with her gynecologist, and there are interventions that we did, and now her sensation is better, and she's even had 2 children, so we're very happy about that. So about as many as 80% of females with MS have sexual dysfunction, and only about 19% are ever counseled or offered counseling for sexual dysfunction. Megan and I and other nurse practitioners who work in MS, we ask that issue on the first visit. If it's in front of the spouse, if it's in front of the mother, the father, whoever, we've got it out there. And so that any time a patient comes, we address those issues. But in our practices, we're not shy. And our offices are safe environments. So sexual dysfunction is impacted by decreased self-esteem and body image. I talked about that. Significant impact on your quality of life. And it can draw tension between you and your significant other. And that's when you need to get help and get counseling. And I'll talk about that in a second. And it's often overlooked by healthcare providers. I know the doctors and neurologists in my office probably never address it. And if a patient asks about sexuality or wants to talk about sexual dysfunction, they run the patient down to my office, and that's okay, because I don't mind talking about it. So it's reported to healthcare providers by patients. Approximately 75% of men and 50% of women are open and talking about it, but there are others who just cannot do it. So here are some of the symptoms. On the left, you'll see the primary symptoms of MS. It can be anything that causes you some unrest, anything that makes you reserved about your sexual function. It can be vaginal dryness. It can be poor libido. We have medicines for that now. It can be intensity of orgasms. It can be anything. Then there's tertiary, there's secondary symptoms. I'm not going to go over all of them, but when you get the video, then you can sit and look at those and see if you fit in any of these categories. Did you know there is rehabilitation for sexual dysfunction? That's a good thing. That's a good thing, ladies. It's a good thing, men, to be able to rehab sexual dysfunction. So we involve the multidisciplinary team. And so they assess these issues. They assess the primary and secondary symptoms. They provide education or rehabilitation, and provides education and empowerment, and helps you transition to solving that problem. I used to work years ago in the dark ages. I worked in brain injury rehab. I spent most of my career in the brain injury or brain diagnoses, and we took care of people with stroke, a lot of women with stroke, a lot of men with stroke, and so positioning was really difficult for them. And I've carried over that knowledge with my MS patients. The best person to see about positioning or altered positioning is an occupational therapist. They are great at providing sexual advice and help. So then there's communication skills between partners and between patients and their medical team. So it's a team effort. But the most important person probably is going to be the psychologist. So I didn't know any sexual psychologists in Orlando, and I looked them up. Sexual psychology, and we have 7 in Orlando that work with patients on sexuality. So I'm sure there's a few here in Fort Lauderdale, Miami area. So counseling that targets intimacy and sexuality is important. And then the psychologist. To me, we do a lot of counseling. We have our own psychologists. We have our own neuropsychologists at the office. And these people are so valuable. If they walk past my office or past some of the other MPs' office, we grab them and pull them in. They're always offer us great advice, and they do counsel with our patients. So coping with sexuality, you should go to counseling. You will probably, if you do rehabilitation, you'll go to counseling by yourself. Then you'll go to counseling with your significant other. There's individual psychotherapy, and that gives you insight into your own sense of self and body image. Then there's anger management, if that's a problem. And then there are psychopharmacologic management, which means medications that can be prescribed. So then we send you to your gynecologist. We send you to your primary care. We send the men to their urologist. We want to make sure everything structurally is okay and get their advice as well. And then we try to treat the underlying symptoms. For instance, if you have spasticity and we have to help you learn different positions, we can do that. Actually, the OTs do that, but I do that sometimes too. And then there may be lifestyle changes. There may be counseling that needs to happen with regards to your cultural history, and that's available. And the key to successful management is open and honest communication. So if you go to a psychologist or you're sitting in an office with your spouse, regardless of if you've never been open and honest before, you need to be open and honest. So these are pharmacologic interventions for sexual dysfunction, so you'll get a chance to look at those when you review the video. There's medicines for decreased orgasm. There's medicines for poor sensation in the external genitalia. There's medicine for low libido in women, erectile dysfunction, and there are hormones that can help some of those symptoms. So communication, how to talk about sex. And I'm almost done. So when you are concerned about something and you don't know how to talk to your significant other, put pamphlets out. Go get pamphlets. You can go to those stores that you don't ever want to go to because they have toys. And in those stores, you can get little pamphlets. You can get videos. You lay them around the house. At some point, your significant other is going to say to you, "What is this about?" And that opens the door for you to talk. So use those things. Don't accuse. You don't do this, you don't do that, don't do that. Don't criticize or blame, but use words like, I wish, I like, I want. And remember, don't say you want oral sex. That's hard to say, but it's better, whether it's oral sex or it's something else, that you actually show your partner. Showing them is much better. He can't read your mind, so you've got to get it out there. And it's important. It's important. Be aware that you are a unique person, and you are special. So if your partner says, no, I can't do that, remember, that's not a rejection of you. He just can't do that. So you have to be sensitive to their needs as well. And be aware that sexual feelings and preferences may change over time, depending on your health. And then be assertive, as I said, demonstrate. That's sometimes hard to do, but think of ways to do it. And don't expect perfection. You have to practice. I've been married 50 years. I know how to practice. So it's important that you practice, and you'll get better over time. I was a prude when I got married. I was young. I was just barely 20. I didn't know anything about sex. My mother took me on a lunch, and I said, are you going to tell me about sex? She said, no, you'll learn tonight. That was on my wedding day. So anyway, so it's very difficult to go into a sexual relationship like that, but you will get better over time. So this says, love me without fear. You're going to have to help me read it. Treat me without, what does it say? Okay, what's the next one say? Demanding. What's the next one? Okay. Accept me without change, and desire me without inhibition. All of us would like to be loved and accepted in that way. So good luck, get some help, and I appreciate you listening.
You're cool. Look, you only got 3 minutes over, but they loved it, right?
I know, but
did you all love that? Weren't all those people foolish that left a little early? Yeah, they were very foolish. Here's a certificate of appreciation for you. And by the way, she made a mistake with her calendar. She forgot that yesterday was her 50th wedding anniversary.
No, I had made a commitment to Stuart about a year ago, and so I didn't want to pull out of the program, so. Yeah.
Great, thank you.
Okay.
So we're going to have all of our presenters up here now. We're going to set it up for Q&A, all right? All right, come on up, everybody. We're going to start on this side of the room, presenters, where I am.
Okay, the question is for the last lady, the one in pink.
The one in red?
Pink, red, yeah.
Connie, first question's for you.
All right, she mentioned that for ladies, depending on when they were born, something about April or May, there was a higher probability of getting the MS or not, something to that. I didn't catch it quite well. Could you explain that to me again?
Well, there was a study a few years back. I don't remember what it was. Do you, Megan? And it said that babies that are born in April or May have a higher risk of multiple sclerosis than babies born October, November. And I don't remember if it was to a mother with MS, but there was some differential in the time in the northern hemisphere. I think it was in the northern hemisphere where MS is very prevalent.
That's assuming one of the parents has MS.
Yes,
okay.
And that they lived in the northern hemisphere because MS is more prevalent there.
Got it.
Okay.
All right, thanks.
So I didn't be clear.
So on that side of the room, opposite me, who's got a question? All right, put your hands up high so she knows where to go to. Thank you.
Is it okay for 2 questions? Go. Dr. Harris, isolation. I've had MS for 10 years. In the beginning, I didn't feel as bad as I do now, that I'd rather just stay by myself and read or computer or whatever. I've stopped book club. I stopped playing cards. Is it something natural, or what do you suggest I could do to get me back into that mode?
First of all, it will be important to understand what it is that's keeping you from doing the things that you used to do, and that you found previously enjoyable. I mean, it's important for you to do a little introspection and to find out. It's also maybe important to see a mental health professional just to have an assessment, because so much of the isolation, withdrawal, not feeling pleasure or interest in other things can be a symptom of an underlying depression. So it's important to get an assessment done.
Thank you. And then my other question is for Greg. We have a will, and we used a lawyer. We haven't seen this lawyer for 8 years. Do you think we just call and talk to him, or what would happen if at the time that we needed him for our children to process the will, does somebody else step in with him, for him?
Well, the important thing to do is first to look at the will and make sure it still says what you want it to say, and making sure that you still have the original copy of that will. Because if all you have is a copy can't be recorded with the court. Then you have to file a whole bunch of documents as part of the probate proceeding to authenticate a copy of the will, or the equivalent of a lost original of the will. The second part is the probating of a will does not need to be done by the lawyer who created the will. It can be done by any probate attorney that you feel comfortable with, or your children at the time would feel comfortable with utilizing. So speaking with the same lawyer, yes, I would say that's a good thing if you want to make a change to it. If not, just make sure you have the original copy of your will and make sure it says everything that you want it to say. At that point, it really doesn't matter. You don't need to go to a lawyer and pay a fee just to say, okay, is everything okay? If you have the original of it and it was done by a lawyer, it should be a good will. Even if it's, most people ask questions, well, if it was done in New Jersey, is it okay here in Florida? Yes, they will still honor a New Jersey will. We're still all part of the United States. If it was okay there, it's okay here. So don't pay for what you don't need to. Just make sure it says what you want and you have the original.
Thank you, panel, and thank you, Stuart, for presenting a great panel today.
Thank you.
Hello. I actually have a couple of questions. I'll be very brief. My first one is for Dr. Gretchen. She knows how much I appreciate her. I originally found you on Instagram because of researching Olympic athletes and the oxygenation that they have in their muscles, and how they're able to do more than the regular individual just because they're able to tap into that. That's when I found out what neuroplasticity was. And so I found you that way. So my question to you is, what are your thoughts on like Olympic powerlifting and those kinds of exercises in terms of increasing endurance and strength over time? Because in the first few months you'll feel really strong, but then just your thoughts in general on that.
So that's a great question. And most recently, there has been more research.
Hold it closer to you.
Oh, sorry. Most recently, there's been a lot of research on high-intensity interval training. So not necessarily powerlifting, but getting those short, high-intensity bursts and then resting, and then more high intensity and then resting. And there's been a lot of research showing that specifically with multiple sclerosis, that can be really beneficial. And the great thing about that is that it's different for everyone. So if you are someone who's still a runner, your high intensity interval bursts are going to look very different than if you're someone who spends most of your day in a wheelchair. But no matter what level you're at, that high intensity burst and then rest can be very effective. And sometimes that's what power lifters actually do when they're training, but it's specifically that high intensity.
And then I did have one more question that are kind of interrelated for two, and that's, okay, so B12 is something that is some of the supplements that I've heard over and over again. I did start taking it. I do find it's beneficial. So the way that it piggybacks into my next question is HSCT. I've been told that the best time to go ahead and go into the HSCT is while you're well. If you would like a second child, so do I keep up with the same supplements if I want to have a child, and should I do HSCT before or after pregnancy? I know it's kind of a complicated matrix of a question, but
How again does that relate to B12?
well, your supplement protocol, I know that with your medications, you really need to talk to your doctor, but something like B12 or D3, do you need to say like, stop taking them? If you're going to be taking prenatal vitamins, maybe you're doing too much for yourself, you know?
So I think it's important to measure levels of things for which we can measure levels, and B12 is one of those. So if you're B12 deficient, or if you don't metabolize B12 well, then you need to take it in certain forms, either by injection or under the tongue or in methylated forms. But if your B12 level is high and you're taking B12, then you're just going to urinate out the vitamin, so there's no reason to take it. You said HSCT, like hematopoietic stem cell therapy?
Yeah, so at UM, where I'm in Miami, they do it, and one of there's a lab there, a clinic. One of the things that has been expressed to me is that because I'm well enough to do it, it would be a good time to start looking at it, because the more progressed you are in your disease, the less you're after HSCT, because you kind of have to go through a lot to process it. So pregnancy before or after would be my question.
Yeah, so the issue with HSCT and pregnancy would be related to the conditioning regimen. So what chemotherapy are they giving you prior to HSCT, if any? Pardon? So in my opinion, then it really wouldn't matter whether or not you were to become pregnant before or after you received it, because natalizumab now we're actually giving in pregnancy with extended interval dosing. You would just want to make sure that your immune system were healthy enough to become pregnant, and that, if you were to do HSCT before trying to get pregnant, and then if you were going to do HSCT after having a child, you would want to make sure that, which you can't really predict, but how you would handle the HSCT so that you could still care for your child. So I think it's really a matter of weighing the risks and benefits of what potentially could happen with receiving treatment. We know with pregnancy that the better you do prior to becoming pregnant, the better you're likely to do after. And if you're stable on a disease-modifying therapy prior to becoming pregnant, you're more likely to be stable after pregnancy. And you can think of HSCT as a disease-modifying therapy. I don't know if that helps, but it's okay.
All right, we're gonna have to finish this conversation with you two afterwards, all right? Because a lot of people have questions. Sorry to cut you off right now, but
It's fine. It was answered.
The other side.
Good afternoon again. This question is for Craig. Craig, regarding living will and property or estate, how about a estate that the person and their husband, wife, or partner may own overseas, in other countries other than the U.S.? And does the probate court always have to be involved, or is it only used if and when no prior arrangements had been made, or if the family or the children are having disputes among each other as to what each get?
Excellent questions, but when you start dealing with the laws of other countries, typically what I will tell my clients to do if they have properties in other countries is I tell them also to speak with an estate attorney in that other country, because a lot of countries may not have, give authority to a U.S. will in the other country. So sometimes you will have to be going through probate in both countries. But it's also a matter of how the property is actually titled. So there's a lot that goes into it. If a property is titled as a husband and wife and one person passes away, it automatically goes to the other spouse. Or if a property is between a couple that's not married and it's titled joint tenants with right of survivorship, then the property would automatically go to the other tenant of the property at the time of the passing without the need for probate. So there's a lot that goes into these questions, which could probably take me more than 20 minutes to discuss. But if you're glad, I'll be glad to talk with you outside in more specifics. But it really depends upon how property is titled and whether the other country would have relations with the United States, that the United States could actually have a law or a order enforced here in the other country. But the best choice is to actually have documents created in the other country as well as in the United States. Regarding probate court, it would really depend upon what's in the documents themselves. I'm saying you may not, if a property is titled to a husband and wife, there's no need for probate. It's already taken care of outside of the probate court. Kind of like what I was talking about earlier, I'm saying if you have a beneficiary on a bank account, it's outside of probate. It never needs to go into the probate court. It's already been taken care of pre-need.
Next question here, please.
Hi, for Constance or any other doctor, you mentioned in your presentation about osteoarthritis being more common with women with MS. I'm wondering why that is and what can be done to prevent that.
So osteoporosis is more common in women who are not erect, who have a gait issue. And so if you spend 50 to 75% of your time in a wheelchair, osteoporosis or osteopenia, which is pre-osteoporosis, is more common. Okay. Do you have anything else to say about that?
Was the question what can be done about it?
No, why is it?
Oh, why is it? Yeah. And part of it is because of the lack of the ability to perform weight-bearing exercise that strengthens bones.
Exercise, okay, thanks.
Next, the other side of the room, anybody? Well, if not, I got to run to this one sooner. I'm not running, though.
Okay. This is for Dr. Stengo. What is the difference, or is there a difference between a relapse and an exacerbation?
No difference.
No difference.
So, yeah,
okay.
I mean,
so
there's many words that cover the same thing. So
okay,
it's
so
exactly the same thing.
Let's say for 2 days you have spastic legs. Is that considered a relapse or an exacerbation? Or is that just the disease?
Well, I mean, it's variable in different people. So we defined before, remember we said a relapse is either a completely new symptom or a worsening of an old symptom that lasts for at least 24 hours. And on the other hand, though, symptoms of MS, people have good and bad days. So you have to evaluate it. So for example, let's say you have flu or a fever and you feel a little more spastic. That could be just related to the underlying condition. But if there's no change, no fever, no flu, nothing else going on, and you just have an increase in symptoms, that could be a relapse.
Okay, and then let's say that does happen. No, you have no other symptoms but the spasticity. Do you call your doctor? Do you just wait for it to go away?
So it's like the disease itself is very variable, and people's responses are very variable. It depends how long you've had MS. If you're earlier in the diagnosis, you might not know what to do, then certainly call. There's never any harm in calling. In our office, and I'm sure everyone else here, we have a portal. So you can write to me, you can email me and say, I have this symptom, and then I can respond back and say, have you tried this, or ask you some questions. Do you have fever? Some questions. Common problem people with MS have is a urinary tract infection. A urinary tract infection often increases symptoms without typical symptoms. Someone who you don't have burning, you don't have fever, you don't have frequency, all of a sudden symptoms get worse. And one of the things I check, so the typical call I get is Friday night at 6 p.m. that someone's going to tell me that's a Friday night 6 p.m. symptom. The first thing I'm going to say is, let's check your urine. So we always need to seek, is there something underlying that's not obvious that could be increasing the symptoms?
Anybody on the other side of the room yet? Raise your hand if you have a question, please. No questions. Everybody there knows it all.
Dr. Steingo. Well, 2 questions. The first one is for Dr. Steingo. You mentioned supplements being inappropriate or a waste of money. Is that an individual thing, or are there any generalities?
I mean, I didn't say that one, but I can answer it from my standpoint, and then you probably Megan mentioned that one. What we're saying about vitamin B12 is the one we're talking about. A lot of people say they're taking B12 because it gives them energy. Well, if your B12 is deficient, so we can measure your level. As Megan said, there are some supplements like vitamin B12 and vitamin D. We can measure your level, and so we can tell you exactly how much to take. But if we measure your B12 level and it's normal, to take extra B12 for energy is ridiculous. Maybe it's good though, because it's a placebo maybe. So, but M&Ms taste better, so you could do that just as well. So B12, we can measure the level. Once you know your level, you know how much to take. If you take too much, the good thing is it's a water-soluble vitamin, it will be excreted. Vitamin D, on the other hand, if you take too much, it gets deposited in fatty tissues and it can become toxic. So vitamins you can measure, you should measure the level.
Okay, thank you. Dr. Megan, you mentioned the masks that are good to block out blue light. I'm sorry, the blue light blocker sunglasses. But I was going to ask you, are the eye masks good for those as well?
So they're blue light blocking lenses, so they're not sunglasses. They're really more of a clear lens that has a filter in it. And the purpose of those is so that you can continue to use screen devices, but you're not receiving the blue light. So if you had a mask on, you wouldn't be able to see. So if you're using a mask just to block out blue light, sure, you could do that if your partner who's in bed with you is reading his phone or iPad and it bothered you. But the purpose is more for you to decrease exposure to blue light from your own screen time. Does that make sense?
Again, any questions on the other side? Oh, there you go. Great.
This question is for Dr. Steingo. How often should we have our vitamin D levels checked?
So at the beginning, we would check your level. If your level's low, until we get it up, we're going to maybe follow it more often, every 3 to 6 months. Once you have an established level and you're taking, an established dose, it'll be less often. It might only be an annual thing. So I think, again, as with every other thing with MS, it's very individual. But it would depend on your initial levels and the dose you're taking.
Okay, I'm not trying to put anybody on the spot, so don't feel like you have to answer, because so far I haven't found a doctor yet that'll give me a straight answer. CCSVI, anybody familiar with that?
Yes, we all are. So each one of us on the panel will give you an answer. My answer is waste of time. Your answer, Connie? Waste of time?
Same thing. So
waste of time.
The studies that were initially done looked like they were it was a potentially beneficial procedure for decreasing relapses in people who actually also stayed on their disease-modifying therapy. But then when they redid the study, which is necessary to validate research, when they redid the study in several different centers, there were actually 2 studies that disproved the original study. And then there were several deaths in these studies, and then just in people receiving the procedure without the purview of a medical research study. So I agree that there's no disease-modifying therapy benefit from CCSVI, and the risk is much greater than the potential for benefit.
Questions? Anybody have a question there? I see somebody
question
with a hand
over
up.
here.
There you go.
Panel, CBD oil impact on MS patients. Anybody has an opinion on it?
I'll do it. There's no research. So the research that has been done is with medical cannabis and THC products and oral cannabinoid extracts, so cannabis, not CBD oil. There's actually very little human research in CBD oil. The research that's done really across the board is with medical cannabis, and it's inherently hard to do because you really can only do it through one avenue in the federal government. The research that has been done in MS has been with THC and oral cannabis extracts, and there's low levels of evidence that it can be effective for treatment refractory spasticity, for bladder dysfunction, and for central pain. So I'm not sure that answered the question, but the answer is there is no answer. Yeah, it's the wild, wild west.
Put the mic by him.
So that's the research that we have so far is with medical cannabis, not with CBD oil.
Great. I'm running off of that side, but somebody just sent me a text and they want to know what's the appropriate level for vitamin D. Fight among who's going to answer.
I mean, in general for MS patients, we aim for higher levels. So for most labs, the lab recommendation is 30 to 100. But in MS patients in general, I'm aiming for a level of 60 to 80. So a higher level than we do for non-MS patients.
Yeah.
Yeah, that's
Yeah, we all agree, higher level, 60 to 80.
Yeah, my question is about biotin. Is it recommended to take a biotin supplement? And if so, at what strength? I've been taking about, forgot how many milligrams, 10,000 micrograms a day. Is that too much, or is it something that can be measured in your blood?
So the high-dose biotin studies were actually with 30,000 micrograms, which is difficult to take. So it would be, well, I'm not sure how many pills you're taking now, but okay. So it's hard to find 30,000 micrograms of biotin to take. As I said in my presentation, the initial study that looked at high-dose biotin from a pharmaceutical grade preparation showed improvement in walking in people with progressive MS, but when they followed the trial, when they followed those people over time, and then in another trial, the people who took high-dose biotin had more enhancing lesions and had a greater relapse rate than those who didn't. And so without larger trials, I don't advise my patients to seek out high-dose biotin until we have more information. And my opinion, that's my opinion. Other physicians, other providers are advising high-dose biotin.
I would agree with that, and also add that biotin is very important when you're having lab tests. Biotin interferes with many lab studies, including common lab studies that you might have with MS, such as vitamin D, vitamin B12, thyroid. All of those lab studies are messed up if you're taking high-dose biotin. So if you are taking it, you need to stop at a good time before you do any lab work.
Wasn't me. Next question here, please.
Hello, this is, I guess, for Dr. Steingo. Hi, sir. Okay, so real quick, we heard earlier about drive-by attorneys. There are also a subset of drive-by neurologists. They don't know what they're doing with you, and you'll end up kind of being bounced around, not sure what's happening. I went through 3 different neurologists before Dr. Sharamata, may he rest in peace, saved my life. So question, Myers cocktails helping the body, what do you think of them? Because I started that after he passed away, so I don't have his thoughts on things, on that. Now, have they been beneficial to me? Yes. But do I know that I would like, I guess, a reputable neurologist's thoughts on Myers cocktails? That's my question.
Myers cocktails.
Myers cocktails are like an infusion of different vitamins that they put through you, and I'm not even sure what's in them, but they do make you feel better, and it's M-E-Y-E-R, Meyer. Sugar.
This is our supplement and vitamin expert, but I wouldn't recommend it.
Yeah, so I agree. So in the Myers cocktail, which there are clinics that provide these specifically to people with multiple sclerosis, and they tout them as high-dose antioxidants that are good for you. So in MS, actually, one of the components of a Myers cocktail is high-dose vitamin C, and we actually shelf the upper limit of recommended vitamin C per day at about 250, 500 milligrams in MS because it can theoretically boost your immune system, which works wrong. So I would caution you about using Myers cocktail. The potential benefit that's immediate could be just from hydration.
Thank you.
You're welcome.
All right. We're getting around the room. Yeah, I got one back here and then one there. Do you have one there? Okay, go for it.
So I have a question. If you are actually taking THC, how would that affect any of your disease-modifying treatments, or is it specific to whatever you're on? Dr. Stenger, you can answer this when you're my doctor. Go ahead.
I mean, my answer is there's no evidence of that. So there's no extensive studies. As Megan said, there are some studies with THC, which help to some extent, maybe predominantly pain and spasticity, and to a lesser degree bladder, but they do not, there is no evidence at all that THC has any effect on disease modulation. and nor is there any study that's commented, no studies where THC has been combined with particular drugs and showing any additive benefit. So they're two separate things. The one thing is addressing your disease, and THC is addressing symptoms, and we just work on them both at the same time.
There's a question from this side of the room. Person wants to know if there's any studies or what the progress is on remyelination.
Yes, there are studies on remyelination. The internet is full of stuff about remyelination. So anybody who wants to spend thousands of dollars can buy all kinds of alternative medicines. But there are studies that are going on with remyelination, particularly the one study I actually had put on my slides. Biogen is doing one study already in progress called anti-lingo. So we know there are substances in the body that inhibit myelination. So when myelin is damaged and myelin has to regrow, there are naturally occurring substances that inhibit that. And Biogen has two trials. One is well underway, and another new trial is starting with a Biogen product to try and promote remyelination. So the answer to that question is yes, there are drugs in study to promote remyelination.
Okay, any questions on that side? All right, if not, I got to run to the front. My interpretation.
This is for any of the doctors. I was just curious if you knew about the procedure that actress Selma Blair just had about, she basically they reset her immune system. I don't know if it was with stem cells or what, but she went to Germany to do that. Is that something that, is like a lasting procedure type deal, like almost like a cure per se, what they say? And is that something we should be looking into, or just what are your thoughts on it?
I mean, the procedure that most likely is what we have spoken about, HSCT, stem cell therapies, where you're taking your own stem cells, and then we do something to suppress your own bone marrow, inject the stem cells back into you, and when they regrow, hopefully your new immune system is restored. So this is what stem cell therapy does. The purpose of stem cell therapy is to restore or reboot your own immune system. So hopefully when the new immune system regenerates, the new T cells and B cells that regenerate are not going to be autoreactive and no longer attack you. So that is the purpose of HSCT. It is not meant to regrow your nervous system. It's not that kind of, it's not stem cells that make myelin regrow. It's stem cells to repair your immune system. HSCT. That would be the purpose of it.
Quick thing, for anybody leaving the room, please know we're going to need your seminar evaluation forms. If you can go inside the resources room, okay, and just put them on the green table in there, that would be great. All right, and
Stu, can I say something
yes.
too about that? I think it's really important, especially here in Florida. There are a lot of for-profit stem cell clinics, and there really needs to be caution if you're thinking about stem cell therapy and going to a for-profit stem cell clinic. They are not offering the same procedure that's being done in research institutions, and so truthfully at this point, as MS providers, we recommend enrolling in clinical trial to have HSCT rather than seeking it in a for-profit stem cell clinic, which again, the procedure is not the same. The National MS Society website has a really great informational page about stem cell clinics. If you just search it in their search bar, you can read a lot about the current environment.
Any other questions? So what I would like to do right now, a little bit something new, 20 seconds each, what each of you have to say that you think the audience will want to hear. 20 seconds each. Start with Rick. Dr. Harris.
Go ahead, put me on the spot. Again, I just wanted to thank Stuart and MS Views for this opportunity, and remember the 3 things I said that can help with the psychological implications: be here now, breathe, and dance.
I love that. I think for me, as long as you can understand how you can actually improve no matter what level of MS you have or how long you've had it, if you can understand those principles of how you can improve and start implementing those, you can make a drastic difference in your function in day-to-day activities and day-to-day life right now. So I think it's just important to keep that hope. If you don't have that hope, learn about it so that you can get hope and get started.
Again, thank you, Stuart. I'd like to say that I really believe that we have most of what we need to heal within our own selves by the way we think, the way we move, what we put into our mouths, and the people we bring into our lives and the way we think. And so I would encourage all of you to feel empowered by that as you're constantly barraged with information that suggests otherwise. Just keep in mind how strong you are as beautiful human beings, as Connie said.
Go Miami Dolphins.
Yes, go Gators. Oh, no, go Gators.
You know, I can say all of us here are dedicated. My practice is dedicated to MS. Every day I deal with MS. I read about MS. I talk to people about MS. I read about it. I get educated. I want everyone to be part of the team. Self-power is what we talk about. Be part of the team. It's not only up to what we do. You guys need to be part of the team and doing all the things that we want you to do as well. So knowledge is power.
I just want to say, women, you are beautiful. Believe in yourself. Get help, get counseling, and you can change and revolutionize your life.
And may I add, men, you are handsome.
I'm sorry,
And the only thing I want to say is, for everybody, please speak with your caregiver. Let them know what you're experiencing, what you are feeling, and what your desires are. Because if they don't know, there's no way they're going to be able to assist and truly take care of you. And lastly, get your documents done.
And now I will say again, I want to thank our sponsors again: Celgene, Novartis, Memorial Healthcare, Genentech, Sanofi Genzyme, Mallinckrodt, Curaleaf, Biogen, and all others that we're here to display today. I want to thank you all for coming here. I want to thank our presenters. This was probably the best panel we've ever had. All right, great. And hey, live your lives. That's all I'm going to say. All right? As I have learned and I have taught MS to live my life and not the other way around. And I hope that you all can do that as well. All right? Live it, do it. Don't wait for a cure. Just get out there and be yourselves. Okay? Have a great day, everybody. Drive carefully. Thank you.